Now, allow me to introduce our panelists for the session of public health. Professor Navario will also be the chair of this panel. Joining him is Dr. Ralph Joseph DiClemente, professor at NYU, whose research has significantly impacted community and technology-based public health interventions. Dr. DiClemente's work in reducing the risk of HIV, STD, and diabetes amongst vulnerable populations is both pioneering and inspirational. We are also privileged to have Jean-Louis Lelogeais, chairman of the board of the Cerebral Palsy Alliance Research Foundation. Mr. Lelogeais brings a unique perspective to our discussion, exploring the role of public health policies in screening, diagnosing, and providing supportive treatment. Next, we welcome Dr. Gbenga Ogedegbe, a renowned expert on health disparities. Dr. Ogedegbe's work in cardiovascular risk reduction and non-communicable disease in minority populations has been groundbreaking, earning him several prestigious awards and global recognition. Finally, we have Dr. Scott Rivkees, professor and interim chair at Brown University School of Public Health. Dr. Rivkees, with his extensive experience as the Surgeon General of Florida, particularly during the COVID-19 pandemic, brings great insights into pandemic preparedness, health leadership, and public health leadership. Ladies and gentlemen, as we delve into this topic, please join me in welcoming the panel of distinguished experts. Their collective wisdom and experience promises a session filled with impactful discussions and innovative solutions for public health challenges.
Is this, yep, we're good. All right, so it's my pleasure to chair this panel today. I'm gonna start with Scott at the far end there, first question. The framing for my remarks were really around this pandemic moment that we're in. And I'd love to hear you talk about, given your experience working on the front lines of the COVID pandemic, maybe you can share some of the takeaways around COVID prevention and treatment. What are some of the priorities here in the United States? In particular, lessons learned, that sort of thing. It would be great to just get your reflections on sort of where we are in terms of pandemic response here in the United States.
Yeah, thanks so much, Peter. First, I want to say at the onset, I really want to thank Charlie and the rest of his team. I know for all of us who are part of the panelists, this is really amazing, and for all of you who are here giving up your Saturday to come, I mean, this is really important. So a couple of things. So first, let's talk about what went well during the pandemic, and I'll talk about 3 opportunities. In terms of what went well, the science went really well, which Peter alluded to. We developed we had vaccines within 9 months of this having the genetic sequence of COVID-19, which we had within 10 days of the virus first being found. We ended up having antiviral agents. We ended up having monoclonal antibodies. And if you look at COVID now, COVID should not be a fatal disease if an individual is vaccinated and gets early treatment with monoclonal antibodies. The mortality rate should be nil. Do we have any public health students here? I can't. All right, so I won't pick on you since you're the only one here. But there are 5,000 to 10,000 people dying a month in the United States from COVID now. 2% of all deaths in the United States are due to COVID at a time when this really should not be a fatal disease. So so this brings us into what are the opportunities? I could break it down to 3 things: structure of public health, engagement, and communication. So in terms of structure of public health, in the United States, it's a very decentralized system. It's up to the individual states to determine their public health department structures and how they're going to respond. This is a very vast, very diverse country. We have urban areas, rural areas, frontier areas. Politically, states are very different, but there is not a unified response. So that is a very important issue. You know, this is also an issue in terms of globally. In terms of engagement, I think we'll hear from the other panelists, it is so critical for public health to have community partners. And these community partnerships, particularly for populations that are vulnerable, can't just start overnight. During the pandemic, we knew that individuals who were older, individuals with underlying medical conditions were especially vulnerable. So having ties with senior organizations, agencies, organizations representing people who are medically vulnerable is really key to be able to mobilize very quickly. The first panel was about the business community. You know, how do we make sure we have ties between public health and commerce? I think a lot of the conflict we started hearing early in the pandemic was pushback against the lockdowns, pushbacks against school closures, and that probably could have happened differently. And then also, the last point in terms of communication. We got the science right. We didn't get the science behind communication right. We've seen the attack on the expert. Attacks on Tony Fauci. The model of the person behind the podium doesn't work now. We have social media. We have so many different ways that people get their news. And then also, again, we have a very diverse country. How do we make sure that we are engaging all different individuals? So those are just some of the high-level areas that I think that we can continue to build upon and continue to better during COVID, which is still affecting us now and in the future. So thank you, Peter.
Thanks, Scott. I'll just go in order then. So Gbenga, I'll go to you next. I'm curious about your thoughts in as you look ahead at where we are with non-communicable diseases and all the work that you've done, particularly with marginalized communities in low resource settings. Generally, where are we with NCD responses in these places, and how, I'm curious if you have any thoughts about how COVID has impacted the sort of global NCD research agenda, that sort of thing. Has anything changed? So I'd love to hear your reflections on that.
Yeah, thank you. Thanks, Charles, for inviting us here. I'm truly honored to be part of this panel. But I'll do two things, Peter, if it's okay. I'll just reflect a bit on what we just heard from Professor Rivkees. So if you look at the COVID pandemic, right? You've heard about the failures we've had in terms of how we look at our healthcare system. Just take a look at what happened in the US. Black folks and Hispanics 2 to 3 times more likely to be infected. If you look at life expectancy, there's a gap between black folks and white folks in the US. Actually, take Manhattan, life expectancy is 5 years higher than what you see in Harlem, which is just several blocks up from us here. All that to say that your zip code is a major predictor of your life expectancy than your genetic code. Let me say that again. Where you live matters. So what COVID pandemic showed us in the US is that the influences, or what I'll call the vestiges of structural racism actually showed itself. My wife is an ED doc. She saw the first patient in New Jersey. And she got home and we're watching CNN News. And what we're hearing people say on the news is that, black folks are somewhat more susceptible to the virus than others. And they have higher comorbidity, which is not a lie that they have more hypertension, more diabetes. But I said, no, that's not the answer. Because if that was the answer, then we should have a higher rate in the elderly as well as a higher rate in people who have comorbid conditions. We did, but it was much more in black folks. We began to then peel off the layers. We looked at our data at NYU Langone Health. We looked at 15,000 patients that we had seen. New York City was hit hard. And we asked the question, if you make it to the hospital, what is your likelihood of mortality? If we look at your zip code, does that make a difference? Guess what? If you make it to the hospital, black folks were 30% more likely to actually survive than white folks. Secondly, if you put on your zip code as part of the variable, it tells us a totally different story. So where you live matters, and I think what we learned from the COVID pandemic is that there's a huge mistrust of the establishment. Number two, people who live in low-income neighborhoods that have been deprived, chronic disinvestment, they have what they call hospital deserts, primary care deserts. And most of the folks, they actually do work in social services, so they didn't have to work from home. So your socioeconomic status also does matter. And then if you look at life expectancy, within 6 months alone, 3 years is what we lost. If you're in the public health world, it takes about 30 years to narrow the gap between one person and the other by about 5 years. We've lost 3 decades of success that we've made in public health interventions. So I want to just put that out there so we understand. So what does that mean for the work that we're talking about? I think we've got to reimagine how we provide healthcare to people. And the way we see it is that, at least in our Institute for Excellence in Health Equity, is that the conditions in which people live actually matters. We need to take healthcare to where people live, where they work, where they pray, and where they actually exercise. And that's not something we've done a good job of. And we believe that the community clinic linkage model is what's going to drive healthcare. We're beginning to see that now. Now let me go to Peter's question about NCDs. So if you go back, I think about 10 years ago, the United Nations General Assembly was talking about the whole idea of should we be investing in non-communicable diseases. They would say we invested in infectious disease. And I think it was Sir Peter, I'm blanking on his last name, from the Caribbean, that actually championed this whole event at the UN 10, 15 years ago. It became clear that the amount of emphasis that we put on infectious diseases was actually disproportionate. There was not enough money to tackle NCDs. And then what happened? Ebola happened, right? We still didn't budge. Now COVID has happened. We still haven't budged. If anything, there's a disinvestment in NCDs as we have it today than we do in infectious disease. So if you look at the HIV pandemic and the epidemic, we've done a fabulous job as a society to actually, at least in Africa, stave off, right, the rising epidemic of HIV. But guess what people are dying from today? 25% of HIV patients actually have hypertension. About 15% have diabetes. And most are actually going to die, not from HIV, but from the non-communicable disease. The question is, what do we do about that? I was in Tanzania just about 3 months ago. We're somewhere talking to a colleague of ours. We're thinking about how do we integrate the care of non-communicable disease into the infrastructure that's been built by the HIV investment in Africa. You're talking to the person, I'm not going to mention names, who are actually one of the donor partner groups in Tanzania. I said, hey, do you guys invest in NCDs? She goes, we're here to just support HIV. I said, but your people are dying, not from HIV. They're dying from kidney disease. There's dialysis everywhere. They're dying from hypertension. They're having strokes, heart failure. Does it bother you that we should invest in that? She said, well, our mandate, and this goes to the issue of, when we talk about availability, funds are there, but is it accessible to address NCDs? She said, we've never done that, despite hundreds of millions of dollars being invested in that population. So my take is that we haven't done a good job. And I think the COVID pandemic has actually changed that completely for us. Yeah. Sorry for hogging the microphone. This is a very important topic that we have to think about.
No, it's great. And I think it's a critical point, Gbenga, and I think a lot of people don't realize actually that NCDs are responsible for a greater proportion of the disease burden, even in low-income countries where there is a significant infectious disease burden like HIV, TB, or malaria. NCDs are still responsible for the vast majority of disease burden. And the challenges that these systems face is exactly what you were alluding to, which is the double threat of infectious disease and NCDs And now you layer on top of that pandemic response, and it becomes really, really critical to find ways to sort of build the capacity of these systems to respond on different fronts. And after years of chronic underinvestment in the systems, it's a tough thing to do. It's also made more difficult to some degree by the way global health financing works, which you also alluded to, which is donors tend to have very siloed approaches to dealing with these things. So someone is, a development agency or a private foundation decides we're going to fund HIV work, we're going to fund TB work, and it's sort of a very siloed approach, and the investments go uniquely into that particular issue. And this question of integration, which Gbenga also highlighted, is such a critical one. You can make investments in a particular health issue while also thinking about all of the other sort of comorbid diseases, right? And this is also why proponents of investment in primary care advocate for that, because primary care is a platform from where integration is baked in, and so it just makes it easier. If you're making those investments in primary care, it makes it easier for you to respond to threats, whether they be NCDs, infectious disease pandemics, et cetera. Let me shift to Jean-Louis. Jean-Louis, you've spent many years as an advocate for research into a very specific health issue, and we're glad you're here with us today. I'd love to hear you reflect a little bit around your work on raising awareness and doing advocacy for cerebral palsy. And in this moment, I don't know if COVID has shaped your work in any way, but love to hear about your work on the advocacy side.
Yes, thank you very much. Is the microphone working?
I think so.
It's okay, great. And I'll weave the topics that were talked about, between COVID, between the topic of non-communicable disease and the topic of vulnerable communities. And starting point is the cerebral palsy community is a vulnerable community, so COVID was a real topic, in terms of how do you provide services, physical therapy, speech therapy, when that's in person, and that community got affected immediately, and they're very vulnerable. People with disabilities in general are going to be one of those vulnerable community. But the topic of economic access, and I'll talk about it a little bit. But I'd like to try to catch people's attention, because I'm going to approach it from almost a different lens, which is one specific condition. It's actually, cerebral palsy is actually not a disease, although we'd like to use the word cure. But it's a word that everybody has heard. Probably all of you have heard cerebral palsy, but and you guys mostly are much younger than me. But I work in the financial services industry. That's my day job, and 3/4 of the folks I deal with are, MBAs and PhDs and in finance and economics, smart people. And so they hear the word cerebral palsy, but when I ask them, do you know what it is? And I don't do it quite that way, but you can see in the eye, they have no clue what cerebral palsy is, which is a problem. So here we are in 2024, and nobody knows what cerebral palsy is. And cerebral palsy affects the number that we think officially is 18 million people worldwide. That's not the right number. We don't have good directory about what's happening in Africa, in China, in India, so the numbers are bigger. And then the other thing that is happening, they're likely to become bigger, because cerebral palsy, just to tell you what it is, it's really a stroke to infant brain. So it happens either during pregnancy, in the womb of the mother, or it happens during delivery, or it happens in the weeks post-delivery, and very often the babies are premature. They're in the NICU, neonatal intensive care unit. Sometimes, it ties to cardiovascular diseases. You don't have to be my age to fall with a heart attack. Actually, babies' hearts are very unstable. And by the time you resuscitate, lack of oxygen to the brain, you can have CP, right? So CP is very prevalent, and it's likely to increase because, as I was alluded to, the incidence of cerebral palsy increases exponentially with prematurity. Mother has the baby at term, the incidence of CP might be 1 in 1,000. 3 months premature, 1 in 200, right? So the reason why this is super relevant is what we're doing, thankfully, is we're exporting first word technique to developing countries, so in Africa and in China, so something called CPAP that allows to make sure that the babies are resuscitated, that you can intervene. And so what's going to happen is we're going to save babies a lot sooner in Africa and in India, but the corollary is we're going to get CP that happens. So the numbers are going to skyrocket as well. So it was to frame why this is not a small issue. And the other kind of element to highlight in terms of the opportunity or why CP should be on the map is that it's incredibly expensive. The economic burden to society of CP is massive, right? My dad died of cancer. He was in and out of hospital for 2 years, pancreatic cancer. Okay, that's a big cost. I mean, it was all covered because he was in France, and it's a different healthcare system. but CP happens at birth, and it's not a disease, it's a lifetime. So if you have a kid that's nonverbal, non-motor, and needs 24/7 care, you can do the math of what that's going to cost. So economic costs, but it's also the opportunity, because very often a kid with CP, nonverbal, non-motor, is very smart. There's a smart brain trapped inside, right? It could be the next Steve Hawkins, right? So our job is also to unleash all that. So just wanted to highlight kind of a little bit what the challenges are. And then now we get to kind of, the potentially kind of the failures of healthcare system. And you don't have to go all the way to developing countries, you just go to the States. So Australia, our foundation, by the way, Cerebral Palsy Alliance Research Foundation is the leading foundation doing medical research, allocating resources, private foundation allocating resources to cerebral palsy research and implementation. And we're working side by side with a foundation in Australia that's called Cerebral Palsy Alliance, that's actually much more advanced than us, and they've given about 60-70 million of private capital to different scientists across the globe over the past 10 years. By the way, 60 million is nothing, it should be multiple. But anyways, they have the chance that in Australia, the healthcare system is top down, you can implement things. Over the past 10 years, they've implemented a set of few very simple practices, pre-birth, at delivery, post-birth, early diagnosis of CP. The incidence of CP in Australia has declined from 1 in 300 babies to 1 in 700 in 10 years. And at the same time, not only the incidence has diminished, but the severity. In other words, the kid is born with CP. Instead of being on a wheelchair, actually, he might be able to walk just because you got a diagnostic earlier and intervene. Those are the numbers in Australia. The number in the States is 1 in 300. It's insane, right? Here we are supposed to be in the States. When you don't have to go to kind of Uganda. You're saying in the States, we're not even capable to kind of adopt practices that already exist in Australia, right? So that gives you the challenges. And needless to say, and it ties to your comments, that 1 in 300, Colombia, of course they do all the same practice as in Australia, but you go to the next hospital in Ireland and you won't get that, right? So I'm here to say, those are the challenges. And then the last point to weave into your point, Peter, is when because my job is obviously to find private capital and eventually also to get on the radar screen of the CDC and the NIH. But I would say also the reason why CP should have a seat on the table, sometimes I say I'm not trying to take resources away, like you said, from cancer research or Parkinson's. I mean, I'm jealous of Michael J. Fox and what they're doing for Parkinson's. But I'm saying regardless, we should have a seat at the table, because very often there's synergies in the research, whether it be stem cells, genetics, the application of technology. There's a lot of kind of brain-computer interface work we do. And sometimes it's a different lens of having a different disease or condition at the table that opens different pathways. So for example, Parkinson's, it's an old people's disease. But you have uncontrollable movement. That happens in CP as well. So deep brain stimulation, there's some pathways that are kind of very, very interesting. But if you approach it from our lens, which is, it's an injury to the infant brain that seems to be causing, in certain cases, uncontrollable movements, you know, maybe there's going to be an angle of research that's helpful to Michael J. Fox in Parkinson's, you know, that's looking at it from a different perspective. So anyways, I'm highlighting more of the challenges. I'm not a global policy nor a doctor, so I don't have the answers, but I'm just saying, you know, look, you know, we have a lot of work on our table if CP is not even in the map in the States, you know.
You have the money, so it's good.
Thanks, Jean-Louis. And I think this, you know, this sort of, again, you sort of revisited this issue of integration across health issues and sort of moving away from siloed approaches to public health solutions and finding commonalities between different health issues is really critical. Leveraging investments across different disease states is really critical. So thanks for highlighting that and the great work that you're doing on trying to raise awareness around cerebral palsy. So I'll come to my friend and colleague from NYU, Ralph DiClemente. Last, Ralph, you and I have shared sort of a thematic interest in public health around HIV, working with marginalized communities, and again, trying to increase access to essential health services for those marginalized communities. Your work is also focused on leveraging technology to sort of enhance access to prevention, care, and treatment. And I wonder if you could talk a little bit about that. Again, there's a little bit of a sort of a community engagement thread that's sort of weaving its way through the comments of the various panelists. So maybe you could shed some light from your career working on community-based interventions that leverage technology for health.
Yeah, thank you, Peter. And I'd like to begin by thanking Charlie and the organizing committee for the privilege and the opportunity to be here today. So I'd like to provide some context for my remarks, and there'll be several key points. One point is, while the COVID pandemic riveted the attention of the United States and certainly the world, and justifiably so, we may have lost sight of another pandemic looming on the horizon, non-communicable diseases. My friend Gbenga talked about it and is the expert in the area. In fact, it may not even be on the horizon, it may be here. Not only in the US, but as Peter points out, even in low middle income countries, NCDs or non-communicable diseases account for a considerable mortality. But the diseases themselves are essentially a syndemic. Each of these conditions, stroke, heart attack, diabetes for sure, are all epidemic. And multiple epidemics simultaneously that overlap essentially are called syndemics. So we are confronting a major syndemic, not only in the US, but globally. One thing about these conditions or diseases, they have underlying root causes. One of those root causes is behavior, or I should say the lack of health protective behavior. So the question we confront, or I confront, is how do we modify people's behavior? How do we persuade people to adopt healthy behaviors as one strategy to avoid the onset, or even if you have the condition, disease progression? The second key point is that the current models of funding healthcare and prevention are woefully lacking. While with the increase in the non-communicable diseases, we've also, and it may not be coincidental, have observed a marked decrease in life expectancy in the United States. In fact, the curve is going down. We are not living as long as we used to. And maybe part of it is also related to our resource and support. In the United States, we spend roughly $3.6 trillion on health. Out of that sum Guess how much is allocated for prevention or public health? Less than 3%. Less than 3% of our health expenditure goes toward prevention and public health. So we are confronting a disease after the disease has already been in effect, after a person has a stroke, after they have heart disease, after they have diabetes, rather than on the front end trying to prevent the acquisition of diabetes or having a stroke or heart disease. So one thing we need to do is to change that equation. Essentially, we are confronting the 21st century health crisis with a 20th century model of healthcare and 20th century resourcing. Now, that leads me to my point. Hybrid models that are adequately resourced have an incredible promise and potential to enhance both prevention and to enhance treatment for non-communicable diseases as well as infectious diseases. We're in the midst of a technological revolution, a revolution that is accelerating and is rapidly evolving. Now, the allure of technology is great. For example, how many people know, how many iterations of the iPhone do we have? I have a 15. Does anyone have a 16? They will be out this year. But just to make this point, the iPhone the first iteration came out only 17 years ago. Within 17 years of its advent, we have 15 generations of the iPhone. My iPhone right now, my little iPhone in my pocket, has much more storage than the computer system had 20 years ago. I can launch a space shuttle from my iPhone. So technology is incredible, but there's a great deal of technology on the horizon. Artificial intelligence, machine learning, chatbots. How do we take that technology and how do we harness it? How do we use it to promote prevention, public health, and healthy behavior change? But you can't have technology alone. Peter and I were mentioning this, particularly in the context of LMIC. Technology alone, while it's attractive, and we want to do it, by itself is not going to be sufficient to motivate the type of behavior change that will have population level effects on disease. So what I'm suggesting is a hybrid approach where we integrate our technology with community and clinical practice. As my friend Gbenga mentioned, we need to take our healthcare out of the hospitals, out of the clinics, into the communities. Let's meet the people where they are. Let's meet them, and each community is different, is it not? Racial, ethnic, SES, differences, and the communities can adjust to accommodate those differences. So the bottom line is both technology, computers, smartphones, chatbots, etc., implemented programs in communities, clinical settings, designed to reinforce each other and to promote the adoption and sustainment of behaviors. Can I do a survey? Okay, now be honest, because I'll know if you're not telling me the truth. Okay? How many people actually exercise 3 to 4 times a week? Well, you are a healthy bunch. I should have asked this somewhere else. How many people eat fruits and vegetables 5 times a week? God, this is great. I did this, by the way, I did this at a business school and no one raised their hand. So How many people have ever gone on a diet and went off the diet before they reached their target weight? Okay, so overall, we know what we need to do, but adopting those behaviors and sustaining them is really challenging, and you're all very smart people. We're all very smart people. But it's very challenging to make those behavioral changes, particularly long-term. Now, my last point, if I have a minute here. When we talk about health, the first thing that comes to my mind is the absence of disease. I like to change that. I think that bar is set way too low. I'd like to use the World Health Organization definition, that health is not just the absence of disease, it's optimizing your performance, your quality of life, and your productivity. Both social, psychological, physical, and mental. So we should change that bar when we talk about how do we improve health, and not just talk about disease, but how do we enhance people's performance? How do we enhance their quality of life? So at that point, I'll turn it over to Peter.
All right, thanks, Rolf. So I think I'll just sum up with a few sort of common. I think there are some threads that we saw through all the comments. One is as we sort of look at global health, that includes health here in the United States in the future. One critical issue seems to be community engagement in designing healthcare solutions, in mounting health responses to pandemic threats. The community engagement, building that trust, creating effective communication is really essential, whether you're talking about pandemic response, you're talking about NCD, prevention, care, and treatment. And Jean-Louis is here as a member of a community who's doing advocacy to try to advance investment in cerebral palsy. Is a good example of the way community can get engaged in supporting public health movements. And then I think there's also the opportunity to ensure that there just aren't enough resources. I teach health economics at NYU, and the first thing that we sort of establish as a baseline in that class with my students is the demand for healthcare greatly outpaces the availability of resources. There's this sort of inherent scarcity in the healthcare market. So the question is, how can we be smart about the resources that we have in order to maximize our ability to meet the various public health needs that we have? And one of the things that you heard here today is also integrated responses, moving away from siloed approaches to dealing with diseases, HIV responses over here, NCD responses over here, mental health over here, finding ways to make investments that sort of cut across different issues. Jean-Louis highlighted some of the commonalities between cerebral palsy and Parkinson's, for example, that those commonalities can be found across diseases and across health issues. And I think that's also a critical issue. And then there are really important opportunities to leverage technology to increase the efficiency of health responses, of services, of prevention efforts. But technology alone, without sort of that undergirding presence of a functioning healthcare system, evidence has shown that it tends not to work very well. So I would say technology not as a standalone panacea to our health issues, but as an additive to a health system that has adequate investment and is positioned to respond to the day-to-day needs of citizens and communities, as well as to pandemic threats, is essential, and technology has an important role to play in all that. Any final comments from any of the panelists before? And then I think we can take some questions.
I just had interesting, that was when we were preparing for the panel, talking, and because the point you just made about technology is it goes one step beyond. I learned, so I'll take 2 seconds to give you a sense of what Peter is talking about, how technology can really help leapfrog in terms of some health treatments, and in fact kind of help with equity issues. So for example, again, cerebral palsy, early diagnostic is so essential, right? And it used to be that, I'm parent of a 30-year-old daughter with CP, so I know the journey. And, it was always the parents that would start seeing their babies, it's 6 months baby, a year baby, there's something wrong with my baby, right? And you go to the pediatrician and says, no, there's nothing wrong with your baby. And the parents know there's something wrong with the baby, and the freaking pediatrician doesn't know, right? And it used to be it takes 18 months to figure out that your kid has CP, and it's way too late, right? The brain is plastic early on. You want to be able to kind of find out there's CP going on 6 weeks into it, and you can do that with a very simple kind of observation. It's called general movement assessment, and you see it, the kid in the NICU, the jittery movements. You can say there's a high probability this kid has CP, right? And this is where technology, so you train the nurses, to kind of recognize that, but, it doesn't work very well because you get trained, but you forget your training and so on and so forth. So now there's an app, right? It's all you need is your iPhone, and you take that picture and you can give it in the hands of a trained nurse, and that achieves the same purpose. But now with AI, forget the nurse. We got to be able to train AI to say this is the CP, right? Now, think about Uganda right now, and because accessing all this, you would be able to kind of put in the hands through the community of when the parents kind of start thinking there's some take a picture and let's figure out kind of so it would be completely life-changing, right? Except what Peter, you were telling me, I'm kind of like thinking everybody has an iPhone, right? He told me, the smartphones don't exist. So, if you don't have access to technology, then technology is not going to be a solution. So there's even, bigger kind of sets of issues. Let's make sure everybody has an iPhone, because then, in Africa, they'll be able to do banking. They'll also be able to kind of figure out that they can have CP. I mean, it opens up the doors, but we need to make the investment into technology and making it accessible.
Yeah. Smartphones are definitely there, but the penetration of smartphones is just not the same in low-income countries and other places. Do we need to wrap up?
Yes.
Okay. Should we take questions, or is there?
Let's take some Q&A questions. If you have any questions, please raise your hand, and our staff will be giving you the microphone. Anyone? Table 15.
Thank you. Hi, I'm Madeline Dansberger. This was really informative. I work in sustainability, so fun to learn about public health and different things. But I'm curious, from the group more generally, what do you see as being the most effective way to transition incentives to focus on preventative care, given that most of the US healthcare system is highly privatized, highly profit-driven, and there's a lot less money to be made in preventing people from getting sick than having patients? Thank you.
Maybe Scott and Gbenga, do you guys want to take a shot at that, since you're the
Yeah, I mean, such an
practitioners?
important question, such a complicated question on so many different levels. So even if you have incentives in place, you have to have the workforce in place to do this. Right now, there's a huge national shortage of practitioners, physicians, nurses, pretty much all allied health specialties. So even if you put incentives in place, there just may not be people to see patients. But there are ways to address that through loan repayment programs, federal programs to increase enrollment in medical schools, in other areas like that. And then in terms of the other issue, how do you focus on primary care and incentivize that? Again, people have tried different models. People have talked about what are called per capitated systems, where a fee goes to an insurance company, and they try to use that by using more preventative care to try to decrease higher cost utilization. So people are looking at those different types of models. But I will say, the data are mixed on those areas. It gets also back to public health. Public health, question was asking about eating fruits, vegetables, things like that. There are lots of things that actually can happen at the community level, pushed by public health, that can have an impact as well.
I think I have to agree with that. We've knocked down the US health system so much that I want to come from the other angle about the cup is half full. I think the reimbursement model today takes what they call a population health approach. So if I'm the health insurance company, we're doing this work now with Health First. It's a Medicaid managed care organization, where we're saying that if you have to cover a particular zip code and the lives there before you can get a AAA rating, then you've got to make sure you invest in preventive care. The other part is that something called the Medicaid waiver. Now, the government is saying that, at least for New York State, I can speak to this, that we're going to begin to work with community-based organizations. So please bear with this, it's very important. Anytime you see disparities in healthcare, that means one group gets better than the other, you want to look at the so-called the social determinants of health. And those are the conditions in which people live. So is it housing? Is it transportation? Can you afford your utility bills? Is it unstable, if you may, housing, that you have housing but it's not the right type? Or is it that you just don't have the right access to care? In this case, it would be insurance. In those settings, there are people, organizations who do work in that space already. With Medicaid waiver for the health equity, they're now saying they're going to fund those communities to then partner with the healthcare system. What that allows us to begin to do now is the community clinic linkage model. In fact, the group that certifies hospitals is asking most healthcare systems to get certified in how you screen for social needs. Those social needs do matter. I think if I'm living in a poor zip code, I really don't care about exercise. I have competing demands. I've got to feed 4 kids. I have only one job to make that happen. So telling me to eat fruit and vegetables is not going to help me. Get me the right housing, and then we can make the other things happen. I think empowering the CBOs, sorry, Ralph, I don't mean it that way, but it's just the demands that matter. I think these alternative models will begin to make a difference. We're going to have to wait for 10 years to see whether this works or not. With the way the country is going right now, good luck. If they roll back those policies, we're back in our pre-pandemic era of how we look at public health.
Yeah. The incentives are just not. The economic incentives are tough for prevention-focused interventions. Who's paying for them, and how do you know if they're the absence of something happening is difficult to prove, right? Like you only see that in sort of longitudinal data. So it's also a tough economic sell, and the orientation of health systems is around treatment, right? That's just how they're sort of oriented. So I think communities hold.
I was going to say that's where private capital plays a super important role, right? And obviously private capital, major foundations, they see that's our case. We love to prevent. That's where it starts. If we could prevent, we're done, right? So obviously the early intervention treatments is also part of the portfolio. But I think private capital is essential, and is going to be the driving force to then engage policymakers, make the case for the return on investment, so that you can get public capital to support prevention research and so forth. So, but it should be a priority, prevention for sure.
Yeah, I think one of the issues with prevention is it's a paradox. We have the problem because we're trying to measure a non-occurring phenomenon. We're trying to measure something that doesn't occur, people getting sick. As opposed to when people are sick and they come in for care, we can measure those people as they get better. So it's a more of a challenge to sell prevention. But one way to sell it is to demonstrate that it's not only cost effective, but it may be cost savings in the long run.
You're speaking my language, Ralph.
Huh?
You're speaking my language.
I'm speaking his language.
Yeah.
So it may be a cost-saving phenomenon as well. If we can demonstrate that, then insurance companies and other funders would be more inclined. Let me give you an example. We had a project a few years back, and we were going to pay Uber to ferry some of our clients to the clinics for care. And then one of the funders said, well, that's not feasible. It's not a real world situation. Well, guess what? 4 years later, the insurance company now does cover transportation to and from medical visits. So insurance companies realize it's to their benefit to keep people healthy and to do those kinds of things like ferrying people to visits so they can adhere to care. But we're missing one key element, has nothing to do with economics. We need the political capital. We need a political will. Essentially, does anyone play basketball? Okay, great. We need a basketball analogy. We need the equivalent of a full court press, a political full court press that says we value people more than money. And we want to provide those resources because people are worth it. And the first rule of any government is to protect your people.
Other questions? Thank you for your question.
Thank you.
I think we have time for one more.
No, there's one over there.
There's one over here. Go ahead.
Hello? Can you hear me? Oh, okay.
We can hear
Thank you so much for inviting us in here. And I have some complex questions, more detail. Recently, I'm joining a project. Is like I so agreeable with the earlier we can detect for the disease, the earlier we can treatment. So we want to get more clear for the heart failure part, how we subgroup for the heart failure and how we predict to give the treatment is more accuracy. So we want to use the machine learning and the AI to join this project to use the technique to help us to how to predict which heart failure the AFib patient may have. But I got this the problem, there are so many factors and a variable for the patient, like a BMI, age, sex, or the diabetes, a lot of disease we may have. So there seems a lot of variable, but it's so hard to counting all the things. So how do I pick up the more important variable when I doing the research or something like that? I know my question is about a little bit general, but yeah.
Yeah, I can address that for you easily. So most of the research I do is focused on what we call implementation science. And I'm going to use that analogy. So heart failure is a major problem, right? People can't breathe, they die. In most hospitals, by the time you've treated a patient, you send them back home, they may have what we call an exacerbation. In other words, the condition got worse because they changed their diet. So the question you're asking is, and then we're going to admit them again. Once we admit them, every day you spend in a hospital in the US is $1,000. It's a ton of money, but we don't get paid if they come back within 10 days, okay? That means we're losing money. So most health systems now want to use predictive analytics to understand when is that patient going to come back to the hospital again. Here's where you have a problem. If you approach it from the perspective of the fact that you want to prevent readmission, then that makes sense. What you want to do is understand what are the factors that actually affect readmission. Once you figure out those factors, then you can build them into your model. I'll give you an example. Where's that patient coming from? If that patient is coming from a place where they have no social support, you can have your best predictive model. It's not going to solve the problem because once they get back home, if they don't have social support, they don't have house help, anything to help them, they'll be back tomorrow because they can't cook for themselves, they don't have enough diet. So I think you've got to have a conceptual model of what exactly do you want to predict. Is it to predict diagnosis? Is it to predict readmission? Once you understand what that is, then those are the variables you want to look at. Otherwise, you're going to be guilty of what most of us have done for a long time, which is wrong. We just throw everything in there and we find what works, and then we try to shovel it into an existing model, which often is a problem. Yeah, we can talk offline.
Yes, I know, for patients, they feel uncomfortable and they have some symptom when they go to the hospital and they do the blood test. So people may go back to home and they cannot detect their blood test results, so they will go to the hospital again. Mm-hmm. And also the hospital can earn the money, so we can hope have a long time with the patient together cooperate.
Yeah,
okay. I'll focus on what's the a patient come before and come back, what's the difference with the result with this data. Yeah, I hope I can talk with you.
We can talk more.
You all in the later because I have so
the
much.
University of Pennsylvania,
Yeah.
you know what they do? They actually provide housing for patients with heart failure, and they pay for the rent. Why? Because if they don't do that, right, that patient is back in 10 days. We're not talking one patient. We're talking where you're seeing 500 patients a year. 500 times let's say even 20% of those, times that by how many days they come back to the hospital is a lot of money than paying the rent for that patient. I think what you're getting at is if you're in Nigeria or Uganda or Kenya, where, by the time the patient shows up in the hospital, it may be too late. You want to get ahead of the curve for early diagnosis. That's a totally different model. So the point I'm making to you is that don't get lost in the variables. Have a conceptual framework of what exactly you want to do with that model.
Because it's like more like.
Sorry, we have to. I'm told we have to wrap up. So you can you can have a one-on-one question after this. I'm sorry to cut you off, but we have to wrap up. I'm told for lunch. So let me just again thank to World Salon and Charlie for organizing this panel. It's been great to be on it personally, and I'd like to thank all of our fellow panelists for joining as well and for all their contributions. Really, really grateful. So over to you. Thank you.
Big round of applause. It was very insightful. Thank you all. We will now move into our lunch section. We will have our wonderful lunch served by the Harvard Club. Lunch will be served in 5 minutes, and this lunch break is an integral part of today's forum, offering a wonderful opportunity for all attendees to continue engaging in meaningful conversations while enjoying a delightful meal served at your tables. It is a perfect moment to discuss the insights gained from the morning sessions and explore potential collaborations or simply just relax and enjoy the time with your friends. Please enjoy.